From FingerLakes1.com, I'm Josh Durso, and this is Inside the FLX. Here's a question. Where do local vets go to get mental and medical health care? Furthermore, where are the gaps in existing service and what is being done to address them? Today we're joined by Brian, Westlake and Sarah Levis of the VA Healthcare Network. We're going to answer some commonly asked questions, discuss potential opportunities for our vets in the region, and look at ways existing programs could be made better. Our entire chat is coming up right after this quick break. Stay tuned. Today's episode is brought to you by the FingerLakes1.com Marketing Alliance, your one-stop solution for all things local digital marketing. Are you a small business trying to navigate the world of marketing and advertising? There are a lot of options. New Pew research shows that people are overwhelmingly choosing digital over print and radio for local news, and our reach proves that. In 2018 alone, FingerLakes1.com was accessed more than 22.5 million times. FingerLakes1.com has been delivering the most comprehensive news product in the region since the beginning, all the way back in 1999 when internet news seemed like a far-fetched pipe dream. In the 20 years that have followed, millions of readers, viewers, and listeners have been asking for local leads on things to do, places to stay, and services offered. They aren't just clicks or impressions, they're real-life people who want to spend their money. Shouldn't they be spending it with your business? Getting access to those leads, a growing diverse digital audience, is affordable too with the Marketing Alliance. In 2018, the average cup of coffee cost $2.70. If there's anything we know, it's that small business owners live on coffee. That adds up to $81 a month and also happens to be $1 more than a monthly Alliance membership. Get leads, share specials, events, and gain exposure that grows by the minute on FingerLakes1.com. To join or learn more, click on the FLX Deals tab at the top of the FingerLakes1.com homepage or by visiting deals.fingerlakes1.com. All right, Brian, Sarah, thanks for being here today. Obviously, we have a lot to talk about, a lot to get through. So, Brian, let's start with you and describe to us a little bit your role, how you're involved with the VA, and what some of your work looks like.
Sure. Well, first of all, thank you, Josh, for having us here today. We're to talk about the VA and the health care that we provide. So I'm the group practice manager for what we now term the VA Finger Lakes Healthcare System, which is from Rochester, Canandaigua, down into the Bath and the Southern Tier. And so my role in all this is to be working across all the clinical areas to monitor our access to care, to make sure that we've got a good balance in our supply and demand, to make sure veterans can access timely, high-quality care.
And Sarah?
My name is Sarah Levis, and I'm the Mental Health Care Line Manager for the Finger Lakes Healthcare System. So, as Brian said, that's encompassing many counties between Rochester and the Southern Tier for Canandaigua and Bath.
So, today we're talking about access to medical and mental health care for vets. Talk to us a little bit about what kind of the scope of services that are offered through the VA system.
Sure. So locally, we are our primary product line is primary care. We have primary care teams in our Rochester clinics, Canandaigua and Bath, and then we have mental health care, which Sarah can give some more details about. We have some specialty services, and then the other part of the services are geriatric care. We have long-term care facilities, we have outpatient geriatric care, and along that line we have home-based primary care, where we actually have teams going out to see veterans in their homes to deliver primary care to those folks that maybe can't get out to avail themselves of the services at our sites. So.
And Sarah?
My specialty is in the mental health care line, and so we have a wide variety from outpatient services to services that target the severely mentally ill. We also have a mobile outreach team, which was just recently developed in the last 6 months, where we're able to send a team of social workers out into the community if a veteran is identified as needing an assessment that day. We also have significant homeless services for veterans. We have access to about 50 beds every night that we can be able to provide homeless services for. So we have quite the variety, and we also have medication-assisted therapy for our veterans who, in a full array of substance abuse services. So quite a few services.
So I want to talk a little bit about access. What is the definition of access?
Sure, that's a great question. So, and one that you may have seen in the news media nationally about, how do you determine access, and so a few different ways we measure it. So, any new patient that comes into our care, whatever service, generally the rule is if they haven't been seen in the last 2 years or they're brand new to the VA service, then right now how the VA measures that is from the create date of the appointment. In other words, when a scheduler goes in and makes that appointment, that's when the clock ticks, then to when they're scheduled. Okay, so that could be driven by the veteran's preference. They could say, you know what, I'm not ready to be seen right now, but 3 months from now. Well, that's a 3-month wait time. We look at it that way. Now, on a patient that already is established in our services, we use what is called the patient's preferred date. That is usually established by the patient and the provider they're working with to say, clinically, based on that clinical assessment, when do I need to be seen next? And so then that's inputted in our system. It allows us to enter the preferred date of the appointment, and then the wait time is measured to the actual date that appointment occurs. Mm-hmm. So those are the two main ways we measure access from a time stamp, okay? But there are many other ways, because we have a local call center in Canandaigua that we have. They call a scheduling clerk, and we get a triage that call through the Bronx VA hospital. It'll go to a nurse in the Bronx. The Bronx will speak with the patient and find out what's going on with their condition. And then if the nurse determines that they need to be seen within 24 to 48 hours, they'll come back to our local call center, and we actually have a physician who can deliver video to home visits. So if the veteran has the capability to have access a mobile device or a computer, they can interact with a physician right then and there. And really the physician is going to make kind of 3 main determinations. Can I help this patient through that medium? Or does this patient need an emergent visit to an ER, or do they need to be linked in with their primary care provider for further care, or their mental health provider for further care? So access time-stamped, as I mentioned, those two, create date or preferred date, but then we have many other ways for veterans to interact with our care.
Is the big misconception that people typically think access means locations or physical places rather than the approach you guys are sort of making on a day-to-day?
I think so, and I think that we've learned over the last, going on 5 years of access to care, it's not one-dimensional. It's you've got to be able to meet that veteran where we're at. In fact, where they're at. And in fact, another thing we're doing is in primary care, is we're just starting out with a patient newly enrolled. We want that first visit to be with their nurse on their primary care team. Our primary care teams are made up of 4, we call them the core 4, which are a provider, an RN, an LPN, a scheduling clerk, and then a clinical pharmacist and a social worker, kind of extension of that team. Well, anyway, we want to introduce them to their team right early on when they come and engage in care with us. And so we're going to have that nurse reach out to the veteran via a video to home visit if we can, ideally. If not, then a nurse face-to-face visit to begin that clinical assessment, to then determine with that veteran when is it best for you to be seen based on your medical condition. And we'll see them sooner if need be, or if we need to have them see other specialists prior to seeing primary care, go that route as well.
So Sarah, you mentioned the mobile outreach team, and then you mentioned the sort of video connect, the video conferencing style connection.
Yeah.
How important is that aspect in terms of being able to create access in a place that's rural, spread out, and sometimes difficult to navigate for folks who don't have reliable transportation or maybe not reliable housing? Yeah.
Go ahead. I'll let Sarah take it.
So a lot of what Brian was sharing about was specific to a lot of the medical primary care modalities. Under my purview for mental health, we're able to see veterans same day. So if a veteran presents to us either physically or on the phone and asks to be seen, we can see them same day. We have primary care mental health integration social workers who can do that. And oftentimes we're getting the consults from the Veterans Crisis Line where we're able to respond the following morning to anyone who's in crisis. And so that's where the mobile outreach team kind of comes in, where as soon as we're alerted to a veteran who may need someone to come out who may have been maybe not connected to care for a while, maybe have gone through a particular difficult time, doesn't necessarily trust the system for whatever reason. Sometimes it's just easier for the staff to actually go meet the veteran right where you're living or in a community area, because we do cover such rural counties that we're willing to kind of take that extra step and meet folks where they're at. So we're able to see anyone same day that they request for. So
does that also take some of the intimidation of that whole process, or the overwhelming feeling that may come along with seeking out treatment like that?
I think so. The other piece of that Brian kind of alluded to is the video on demand home visits that we're able to do. So, I know when folks typically think about veterans, sometimes they kind of have an idea of what a veteran may look like. But, we have multi-generational veterans who have, either served in Vietnam. We have we still have some Korean folks left, and our newer Iraqi veterans and Afghanistan and Iraqi freedom. So with that in mind, our younger population tends to be very savvy when it comes to technology. And, frankly, they are busy and they have families and lives that they want to, and taking time to kind of go to a medical appointment can seem kind of like a barrier. So what we're trying to do is reduce as many barriers as possible. So many folks have iPhones or smartphones, and the ease of actually, if you will, having a FaceTime visit with your provider, because that's really what the experience is having a FaceTime conversation with your provider, is something that we can do, and we can do it pretty quickly, especially if you request it and you need to have a conversation same day. We can do that to make sure you can have an assessment and kind of get an answer of what's the next level of care that you really need to be at. So we're definitely pushing the envelope in terms of using technology, and it's moving away from that traditional, you have to come to the brick and mortar hospital, but we can find ways to be able to give you the same care.
Now, it's interesting you mentioned the multi-generational aspect of that, because
Sure.
One of the pieces of feedback we were getting leading up to this interview was actually the curiosity of what the demographic sort of looks like
Sure.
with those who are taking advantage of the VA system.
Mm-hmm.
It isn't just that senior citizen population that maybe some folks
Yeah.
might think. Walk us through a little bit of that, or expand on that a little bit.
So
for
that's
us.
one of the beauties of the VA. So you figure somebody who is in the service could get out of the service as early as 18 years old, depending upon what happened within their service career. And then, we have folks that live, beyond 100 years old. And so it's a longitudinal care system that is really exemplified one in our electronic medical record. Our record is such that your care is recorded from the moment you come in from your first visit through the rest of your life, and any clinician across the country really, but in upstate New York in particular, can access that record and see all of your components of your care. Somebody could also see that in San Diego, California, if you decided to travel there. So from the spectrum of what do we treat? Well, it's from 18 to over 100. What else do we treat? We treat veterans who last night may have slept under a bridge. And to that person that can roll up in their Mercedes and pay cash for everything we offer, but choose us because of the quality we produce.
Right.
So you've got to build a healthcare system that delivers the quality equally in those spectrums. And that's what we're driven to do in the VA. And we have the tools to be able to bring that to them as conveniently as possible. Now, you had mentioned about rural areas and care. I'll give you an example. We have a community-based outpatient clinic in Wellsboro, Pennsylvania. And so it's a primary care clinic, but we have telehealth operations there where we have hepatology services, an example. Veteran was seen at the Buffalo VA for a face-to-face visit and then needed follow-up care. Well, we don't want them to have to travel to Buffalo, okay? So instead, we set them up with a cart with a peripheral so they can get a full exam through that from the provider they had originally seen in Buffalo. So we want to make that, again, another example of convenient care for across a spectrum of services. And that's the exciting thing we're in the midst of right now. What we can do with this, we're just beginning.
Well, it sounds like it's a work in progress. It's
Yep.
something you guys are working on every day. How much of it is sort of working to streamline the processes and sort of cut the red tape where you can to make the overall experience less maybe slow and painful like it might have been 10, 15, 20 years ago in the VA system.
Sure, absolutely. And in fact, organizationally, we've deployed a lean management principles throughout our organization where, the Toyota model of developing standard work for processes. I'll give an example of managing consults. Okay, so anytime a veteran is referred, let's say they see their primary care or mental health provider and they want to seek additional service for that veteran, most of that is driven through a consult service. So a consult is submitted. Well, we have used standardized procedures that have somewhat been dictated by central office of VA to adapt locally, but making sure that all the members of our team follow those processes from the time the consult is submitted to when it's scheduled, to the patient is seen and the consult gets closed out. Because we want those visits to take place timely and the information from them to be available for the next clinical decision. So that we work through a lot of processes across our whole clinical side of the house to make sure that is as seamless as possible.
And when you guys are engaging with communities, how much of a challenge or issue is the transportation and housing element, especially for that group who may be in the lower third in terms of the socioeconomic
I'll let Sarah talk about some of the programs from her perspective.
Typically, the veterans that we're seeing who are struggling from that perspective are homeless or are on the verge of becoming homeless. And so we have multi-tiered services through our homeless program. We have preventative services. So if veterans are potentially at risk for being evicted or who are kind of almost going to be on the street, we want to work with them so that they're not going to end up on the street. We have also what's called our HUD-VASH program, where we have subsidized vouchers for folks who meet the criteria for that program. And the VA, in conjunction with HUD and with the veteran, promise together that they'll work together to maintain housing. And so the VA subsidizes the housing based on their income. So we have over 200 vouchers between Bath and Canandaigua that we are managing. So in other words, when we find a veteran and we house the veteran, we stay with the veteran, and we make sure that they remain housed so that they can be as successful as possible. Also with that is our employability services. So we have a wide array of vocational services. And so also if the veteran is interested in returning to work or wants to engage in volunteer services, we absolutely have staff who can help them write their resume, practice their interviewing skills. And we really individualize all of our services based on the veteran's goals. So the other piece that I wanted to make sure that I shared about was, typically the substance abuse arena has historically, I would say in the last 15 to 20 years, definitely taken a step away from the traditional model where you have to be sober in order to maintain your housing. And so 5 years ago, the Canandaigua VA really backed that sentiment and got on board with having a safe haven. And that's a 20-bed facility that is now located in Farmington with our partners. And what that is a 6-month program. So if a veteran is struggling with mental health and or substance abuse and hasn't been able to maintain themselves either in a shelter situation or in a transitional housing situation, Safe Haven is a harm reduction model. So in other words, you don't have to remain sober in order to stay there, because we know that if we keep a roof over your head and we work with you, the better opportunities you're going to have to kind of be successful for your housing and for your treatment, really. So those are a few of the things we have.
So to that end, I want to expand on that a little bit.
Sure.
Substance use disorders within the veteran community.
Sure.
Not always something that is first talked about when we do talk about substance use disorders. So expand on that a little bit and how sort of vets are uniquely impacted by this issue, the opioid epidemic in particular, compared to other groups.
So I think there's many similarities, but there are also some differences. We know that one of the major injuries that from our younger population, if you will, are musculoskeletal disorders, and so often that they've received from being in theater or during their tour, and we know that they have at some point been prescribed medications that in some cases, not all, but have become addicted to, whether it's opiates whether it's alcohol, it could be many different things. And so that's kind of when they leave the service, they transition, and they start finding some negative consequences going on for them, and that kind of snowballs, and that's kind of how we are able to kind of step in and say, hey, how can we help you? But we know that based on some of the physical requirements that a veteran or active duty service member has gone through, that they are more likely to have medical complications, and or hearing loss is also another one. So with that, we have Dr. Matthew Tessina, who is our psychiatrist who's working with us, who's addiction certified. And so he's helped kind of drive us with medication-assisted therapy, buprenorphine clinics and Vivitrol clinics, and really kind of giving our veterans a kind of a springboard, if you will, to be able to kind of work with, and then our clinicians come in and provide different services around that. And some of those services can be offered via televideo. So we've been pretty successful in moving that model forward, and we've seen a lot of success from it. So
as you guys sort of use that as a springboard, the televideo aspect of providing healthcare, is that I'm just very curious, is that the future industry-wide, do you think?
I really think so. I think that, you talk about somebody who's having whatever kind of a medical issue, whether it's medical or mental health component to that, and they can be in their house, and they can connect via the palm of their hand with their mobile device. That's powerful. Mm-hmm. They can be connected with a healthcare professional who can walk next to them to make that next best clinical decision for them. We use mechanics to fix automobiles, and we don't know what's going on until we talk to that mechanic. If we can bring that conveniently to them, that's very promising, and get them connected to that evidence-based care that we deliver it at our facilities. That's powerful stuff in healthcare. As we describe what we, and kind of give you a sense of what we deliver through our VA facilities, I hope you're pleasantly surprised. But the other thing is, it's really a description of incremental medicine versus rescue medicine. And incremental medicine, meaning that you're delivering that care over the lifetime of your patients. And the literature speaks a lot to these two terms, whereas rescue medicine is more of a episodic. Like if you see urgent cares popping up around the area, they're going there episodically to take care of a condition they have right now. Well, there's a lot of conditions such as diabetes, congestive heart failure, hypertension, some mental health conditions, where having that incremental check-in with your team to help you manage those conditions is so key in helping them from escalating to something more. And so you combine the convenience of what we're working on from the telehealth perspective with the incremental approach. I think we've got a great combination that we're just getting started on this front.
So what's been the biggest change, I guess, that's probably the big curiosity over the last decade or so. Yep. What's been the biggest change in terms of what you guys are doing or how you guys are doing it?
Sure. One of the things I will say is the history of the last 5 years in VA was a gut check for the VA. There's no question about it. And so we really looked internally, and I can speak locally, having been right in the middle of that development of access and wait times and all of that, really determining, okay, what really truly is our capacity to in terms of the resources we have, and then balancing that capacity with the demand that's coming in the door. And we have really been able to look very closely at that and balance that supply and demand. And I've actually worked with Sarah's team in the behavioral health side of the house to figure that out. So you take a counseling service, okay, and veterans gets to meet with their therapy counseling services. Well, what's the right dose of visits to do that? And we worked a lot on that, frequency, duration, and if when could they be discharged to another service? But it's figuring that out more intimately, and now we have the artificial intelligence, if you will, to be able to do that, because we have a lot of databases from nationwide data that tell us, how many visits should a primary care provider? What's the panel size of a primary care provider? How many visits should a psychiatrist, psychologist, conceivably be completing in a day? to make sure that the care remains high quality, with high quality time with that patient. So that's been the big game changers over the last 5 years.
So I think, so Brian's really kind of touching on things at a global level, but as I think about it as a clinician, I think the last 10 years we have shifted from more of a traditional medicine approach to a recovery focus, to a veteran-centric, to a consumer-driven system. And so historically, it was really the doctor that was really at the center of the care, and the doctor kind of made recommendations on how you should do things for whatever you may be diagnosed with. And so the VA has really shifted away from that and really put the veteran at the center of that and really asked them to be in the driver's seat to make those clinical decisions for the care that they are eligible for. And so really it's sitting down with a veteran and saying, here's what's going on for you, here are all of the options, which way do you want to go? And really not necessarily putting artificial timelines on any of those, but it's really making sure that they feel comfortable and really are the kind of driver behind their treatment plan. So I think that has been a shift. And so with that, we've also developed in the last, I would say 3 to 4 years, our whole health initiative, which is really fits nicely in with this really consumer-driven, veteran-driven, which is really thinking about alternative ways to be able to kind of supplement our mental health and primary care. So we've had ability to do yoga and Tai Chi and acupuncture. Yep. And so all of those things that we haven't traditionally thought about in a traditional medicine model have really, we've come a long way, and we're thinking a lot differently about that. Not every single treatment plan is going to fit every single veteran, and so we are working very hard to make sure we tailor every single veteran to have their own way of kind of getting healthy. And so they're really kind of the person who's driving that, and we're just there to kind of give them options and let them be if you will, I guess, best informed about how they can move forward.
So I want to get both of your takes, but we'll start with Sarah and start on the ground. What is the biggest opportunity over, say, the next 3 to 5 years, or maybe further than that, in terms of how what you guys do on a daily basis can get better?
So, opportunity for me is really thinking about the veteran population, and we know, and I'm going to bring up the difficult stuff, the conversations about the veterans who are taking their lives. We know 20 veterans per day are really are completing suicide, and we want to really step in and give some interventions so that veterans don't ever have to come to that place. So we know that 14 out of those 20 do not receive care from the VA. And so if I could tell you what's the biggest opportunity for us and for the veteran population, it's to have those 14 enroll in our care. So we know that of the 6 that take their lives, we know that we've been able to provide all of the services to them. But more concerning to me is that we have a population that's deserving of the care that we have and isn't signing up. And there are situations where I say to veterans, you may have health insurance, you may have all of the things that you need, but you just never know when you might need that. And that has come into a couple different times when I've had a geriatric family member come to me and say, my 83-year-old grandfather really needs to get into the nursing home, and he's never been signed up for VA healthcare before, and he is 100% service connected. Can you help me? And he needs hospice. And so unfortunately it takes time to kind of move all of those things down, from a process perspective. And I wouldn't want any veteran to be in a situation where they can't access what they want as soon as they want. And so I often tell veterans that Congress can change eligibility criteria for the VA whenever they choose. So it's helpful if you just come in, get your name on the books, so that you always know that you can access all of the services we have, and we'd love to be able to serve you.
It sounds like you're saying develop a relationship now, so you don't have to worry about it 10, 15, 20, maybe 30 years
That's exactly
from now.
right. And
and you can't predict.
If I could just add one thing to that, if a very simple message to veterans is what Sarah has said. Come to the VA, find out if you're eligible to enroll. If you are, enroll, and then have at least one visit with your primary care doctor a year, okay? Because then what it does is it keeps you connected with care. And if situations arise where you need more support from the VA, we can be there for you. The challenge becomes, as Sarah has described, If you're not enrolled, we can get you enrolled, but it just takes that much more. So.
And what does the volume look like in terms of what, in the Finger Lakes region, what you guys are sort of seeing and encountering in total?
Yeah. So in the kind of the Canandaigua-Rochester catchment area, I'll say, there's about 57,000 veterans that are there, okay? However, we've got about 20,000 that are enrolled, okay? And so this speaks to us wanting to get as many of those 57,000 enrolled as we possibly can to be able to deliver this care that we feel is very high quality. And so that's what we're up against. Now, I will say our brick and mortar structures are being improved. We have a new clinic going up on Calkins Road in Rochester. We're very excited about that's going to be coming on board here hopefully in the next few months. And it's state-of-the-art operations, and then we have 2 satellite clinics that'll house our mental health operations and our physical medicine rehabilitation operations. And then at the Canandaigua site, we've got construction. It looks like an erector set there right now because we have things going up. We're going to have a new outpatient clinic, and then down the road, hopefully some cottage-style long-term care housing for state-of-the-art long-term care.
So the last question I want to throw to both of you guys is just what is what's the message you leave with folks who maybe they aren't veterans, but maybe they know a veteran? What's that message that you leave with them so the community starts to understand what you guys are doing, even if they don't directly benefit themselves from what you guys are doing?
Yeah. Come visit our sites and come to our Veterans Service Center. Every VA has a Veterans Service Center that helps to enroll new veterans. Come in, speak to our representatives, and find out about your eligibility. If you're eligible, enroll, and then connect with your primary care team. If you have a mental health need, connect with your mental health team. We're here for you, and we want to serve you for the great service you gave this nation.
Mm-hmm. And Sarah, from the clinician's perspective, what is the bit that you try to leave with folks when you encounter them, whether they're a veteran or not?
Reach out to us. That we have many different ways to connect to us. As Brian said, you can come to our campus, but maybe you're a little hesitant to do that. So look us up online. There's ability to access us online, or you can call some of our call centers. We have the Veterans Crisis Line. Yep. We have the Women's Call Center. We have the Homeless Call Center. In the Homeless Call Center. So all of those are 800 numbers that are listed online, and we can provide those to you. But, just reach out, make that connection. And, while we speak specifically to veterans, if you're a family member, we have the Caregiver Support Service. Where we're able to provide support and in some cases a stipend to caregivers who are caring for veterans. And so if you know somebody or if you are a veteran, just reach out. We can help get you connected. You don't have to kind of do the enrollment on your own, and see what you're eligible for. You just might be surprised.
All right, step 1, build a community, get connected. Thank you both for coming in, talking with us. Really important stuff. We'll definitely be having you back to continue this one.
Appreciate it.
Thanks.
Thank you.
Hey guys, thanks for joining us. We will be back next week with another episode. That's every single Thursday right here on FingerLakes1.com inside the FLX. You can also search Inside the FLX in iTunes podcast store. You can also search us on Google Play, Spotify, or wherever you consume your podcast. Be sure to subscribe to our YouTube channel. That's the FingerLakes1.com YouTube channel. And download the FingerLakes1.com app. We'll see you next week. Bye guys.